Hi, this is Dr. Vallish. Welcome to Pharmacology Simplified. In this video, I'm going to briefly speak about myasthenia gravis and its management. This topic is important for your theory exam, practical exam in the form of prescription writing, and viva. And also it is important for your entrance exams. Myasthenia gravis is an autoimmune disorder. It affects the neuromuscular junction. The normal neuromuscular junction, what happens is, whenever impulse arrives at the neuromuscular junction, acetylcholine is released from the presynaptic neuron. This acetylcholine occupies the nicotinic receptors located on the muscle end plate that will lead to muscle contraction. This is normal. What happens in myasthenia gravis is there is formation of autoantibodies against the nicotinic receptor. This is the NM type of nicotinic receptor. If you remember, there are two types of nicotinic receptors. One is NN, other one is NM. In the nerve muscle junction, NM type of nicotinic receptors are present, whereas NN type of receptors are located in synapses, cholinergic synapses. Here, NM type of receptors are located, and autoantibodies are formed against the NM type of nicotinic receptors, and as a result, there is a reduction in the number of nicotinic receptors. So, acetylcholine is released, but there are very few number of nicotinic receptors. As a result, the muscle end plate is not stimulated adequately, so muscle contraction becomes weak. The patient suffers from muscle weakness. So this is the overall pathology in myasthenia gravis. There is a related condition called Lambert-Eaton syndrome. What happens in Lambert-Eaton syndrome again is the manifestation is pretty similar. The patient will suffer from muscle weakness. The pathology also lies in the nerve muscle junction. The pathogenesis is different. Here what happens is, it is also an autoimmune condition. Here also autoantibodies are formed. But the target of the autoantibodies is the voltage gated calcium channels. The calcium influx is essential for release of acetylcholine. So if there is autoantibodies against the voltage gated calcium channels, the release of acetylcholine itself is affected. So in comparison with myasthenia gravis, where normal amount of acetylcholine is released, in Lambert-Eaton syndrome, a less quantity of acetylcholine is released. This acetylcholine sits on the nicotinic receptors. Here, nicotinic receptors are not affected in Lambert-Eaton syndrome. But in myasthenia gravis, nicotinic receptors themselves are reduced. So let us focus on myasthenia gravis. Let us look at the symptoms. The major manifestation of myasthenia gravis is weakness. Weakness in the skeletal muscles. Weakness and easy fatigability on repeated activity. This recovers after rest. So which all muscle groups are involved? The most important muscle groups to be involved, most earliest to be involved, are the eyelid muscles, which will lead to ptosis. Subsequently, external ocular muscles are involved, leading to diplopia or double vision. Then there is involvement of facial muscles and muscles in the pharynx, leading to dysphagia or difficulty in swallowing, and dysarthria or difficulty in speaking. This is followed by involvement of limb muscles, leading to limb muscle weakness. And at the end, respiratory muscles are involved, leading to shortness of breath. So this is the sequence of involvement of muscles. So let us jump to the management of myasthenia gravis. These are all the various treatment options available. Remember, the drug of choice for symptomatic management of myasthenia gravis is oral administration of anticholinesterases, neostigmine and pyridostigmine. Both of these, neostigmine and pyridostigmine, both of these are reversible, water-soluble anticholinesterases. So since they are water-soluble, in comparison with physostigmine, which is lipid soluble. So physostigmine is lipid soluble, it crosses the blood-brain barrier, whereas these two are not lipid soluble, so their actions are confined to the periphery. That is the reason why we use neostigmine or pyridostigmine. We do not use physostigmine for this condition. We don't want action in the CNS. So between these two, neostigmine, pyridostigmine is longer acting. How to remember? Pyridostigmine is the longer word. That is the reason why it is longer acting as well. So pyridostigmine is longer acting. But between these two, neostigmine is more potent. Okay. So if pyridostigmine is given, it is given thrice a day, longer acting. If neostigmine is given, it is shorter acting, so it is given 4 times a day. These two are the best drugs to provide symptomatic relief. Remember, the disease is due to the production of autoantibodies. These drugs are not doing anything to the autoantibodies. These drugs are only helping the patient overcome the symptoms. So these two drugs work well if the patient is having mild to moderate form of the disease. Okay, you can either give neostigmine or pyridostigmine. They have dual mechanism of action. First mechanism we all know, they are anti-cholinesterases. So they block cholinesterase enzyme, and as a result there is accumulation of acetylcholine. This acetylcholine availability increases in the neuromuscular junction, and this will improve the muscle contraction. This is the first mechanism. Second mechanism, a mild mechanism, is that they have a mild minor. Directly they depolarize the muscle end plate. They directly sit and activate the NM receptors. This is a mild minor action. This is not seen with physostigmine. So remember, the drugs of choice for the management of myasthenia gravis, mild to moderate myasthenia gravis, is either oral neostigmine or oral pyridostigmine. Okay. The second drug here is atropine. So what is the role of atropine, which is a muscarinic receptor blocker, in the management of myasthenia gravis, which affects the NM nicotinic receptors? What is the role? What is the connection? For that, we need to understand the complete mechanism of action of neostigmine or pyridostigmine. What they do is that they block the acetylcholinesterase enzyme wherever they are present. Okay, neostigmine, pyridostigmine, their action is not confined to NM receptors. After giving neostigmine, pyridostigmine, acetylcholine availability increases in all types of receptors: NM receptors, NN receptors, muscarinic receptors. Out of these, availability increased in NM receptors is desirable. It is useful for the management of this condition. Increased acetylcholine availability in NN receptors is not clinically significant. But increased acetylcholine availability in muscarinic receptors, that is going to produce GI side effects. Remember, parasympathetic system is for rest and digest purposes. So if you increase acetylcholine availability in GI system, what is going to happen? Rest and digest. So digest, there is increase in intestinal activity. So there is cramps, there is diarrhea. Digest, there is increase in glandular activity, there is salivation. So all these side effects are there. We use atropine, anti-muscarinic agent, to overcome these side effects. That is the purpose of giving atropine in myasthenia gravis. As such, atropine does not have any therapeutic action, therapeutic advantage for giving in myasthenia gravis. Atropine just overcomes the side effect due to neostigmine. As such, even this is not required, because generally tolerance develops to all these muscarinic effects after prolonged neostigmine therapy. So atropine is not always required. Patients who cannot tolerate these side effects, we can give atropine or even glycopyrrolate for that matter for a short duration of time. Next is thymectomy. This is the definitive therapy for management of myasthenia gravis. Okay, so thymus is generally the source of all the autoantibodies. In fact, up to 75% of patients who are having myasthenia gravis are expected to have a thymoma. Okay, thymoma is a tumor in the thymus. So even if a thymoma cannot be demonstrated, if the patient is less than 65 years suffering from severe forms of myasthenia gravis, we should consider thymectomy. But thymectomy, even though it is a definitive therapy, it is not the first line therapy, because remember, it's an invasive procedure. Okay, so if the patient is well controlled with neostigmine or pyridostigmine, we need not even go for thymectomy. But if the patient develops complications, or if the patient the disease worsens in the patient, then we should consider thymectomy. Okay, remember, thymectomy is the definitive therapy. Next is immunosuppressive therapy. Remember that myasthenia gravis is an autoimmune condition, so we can try immunosuppressive therapy to suppress the autoantibody generation or even remove the autoantibodies. So for this, this is not again the first line therapy. First line therapy is always neostigmine. If the response to neostigmine is poor, or if the disease is severe, we can consider immunosuppressive therapy. The best drugs in this case are corticosteroids. If the patient complains of severe disease, we give him or give her corticosteroids. And our aim should be to achieve alternative day low dose corticosteroid therapy. In severe forms of disease, we can consider other immunosuppressive agents such as azathioprine, cyclosporin, tacrolimus, mycophenolate, mofetil. Okay, again, this is not the first line drugs for management. Next is plasmapheresis. What happens in plasmapheresis? We take out the autoantibodies from the plasma and we return the plasma back to the patient. So this is a short-lasting treatment option for the management of severe condition, severe myasthenia gravis, especially in condition where we are planning for a thymectomy and we want to stabilize the patient before we can take him up for the procedure. We can also use plasmapheresis to manage acute crisis, but it is not a long-lasting solution. It's a short-lived. The benefits are short-lived. And finally, we should avoid aminoglycoside antibiotics, because they exacerbate myasthenia gravis. If the patient, when you're planning to prescribe aminoglycoside antibiotics, just make sure that the patient is not suffering from myasthenia gravis, because it is going to worsen the condition. So let me wind up this video by comparing these two important conditions, myasthenic crisis and cholinergic crisis. So what is this? So imagine a patient with myasthenia gravis. You have given neostigmine or pyridostigmine. The patient is well controlled. Symptoms are gone. Few months later, the patient returns complaining of worsening of weakness. So what would have happened here? Patient was well controlled. You have given neostigmine or pyridostigmine. Patient is well controlled. Now the patient complains of weakness. So what would have happened here? It can be either myasthenic crisis or cholinergic crisis, because the symptoms are the same. There is increase in weakness. So why the weakness has returned here? One possibility is that the disease has become worse. There is worsening of the disease. In that case, it is called as myasthenic crisis. That is one possibility. The second possibility is that whatever dose that you have given, neostigmine, pyridostigmine, the dose is high. You have over-treated the condition. And as a result, what has happened? There is increased blockade, increased inhibition of cholinesterase enzyme in the synapses, leading to increased acetylcholine availability in the synapses. And this increased acetylcholine availability has occupied the NM receptors and made them go tired. There is fatigability, there is downregulation of nicotinic receptors in the synapse, and that has led to weakness. This condition is called as cholinergic crisis. So clinically, you will not be able to distinguish the weakness. What is this the weakness due to? Whether it is due to myasthenic crisis or cholinergic crisis. So how do you distinguish? You use edrophonium for distinguishing between myasthenic crisis and cholinergic crisis. What is edrophonium? Edrophonium is a reversible, water-soluble, short-acting, weak anticholinesterase agent. If you remember, edrophonium binds only to the anionic site. It doesn't bind to the cholinergic site. So you give edrophonium, it blocks the functioning of acetylcholinesterase enzyme for a short period of time. It blocks it weakly. So what will happen if you give edrophonium? The patient is having myasthenic crisis. What is going to happen? The patient will recover. The weakness of the patient is going to reduce. On the other hand, what will happen if you give edrophonium to a patient who is actually having cholinergic crisis? In that case, the weakness will become worse. But you need not worry here, because edrophonium produces mild inhibition of acetylcholinesterase enzyme. So whatever worsening of weakness is seen here, it is only temporary. But with administering edrophonium IV, you have determined whether the patient's increase in weakness is because of myasthenic crisis or cholinergic crisis. Now you can manage the patient well. If the patient is having myasthenic crisis, generally myasthenic crisis develops because of some underlying condition. So if the patient is having myasthenic crisis, you have to identify the underlying condition. Generally, it will be an infection or something. You have to manage that underlying condition. If there is no underlying condition, the condition might be because of inadequate or lower dose of acetylcholinesterase inhibitor. So you need to increase the cholinesterase inhibitor dose, neostigmine, pyridostigmine dose. If it is not manageable with that, you have to consider other forms of therapy, including plasmapheresis, thymectomy, and immunosuppression. That is for myasthenic crisis. How do you manage cholinergic crisis? You simply lower the dose of acetylcholinesterase inhibitor. That's it. So I hope I have been able to simplify this topic for you. Thank you. Namaste. Have a nice day.